Hi, everyone. I'm Stephanie Cooper Greenberg in for our beloved Dr. David McConkey, who's actually giving a lecture this afternoon in New York City. So we are here to talk about upper tract urothelial cancer with our experts, Dr. Nirmish Singla and Dr. Jeannie Hoffman-Censits. And we'll get started in a few minutes, allowing a minute or two, just allowing some more people to tune in. And thank you for being with us today, and happy spring. So in a minute, we'll get started, but we'll let everyone have a chance to join us. And we'll just wait one more minute and then get going. And please, if you have any questions, write them in the chat, which we will review and ask our panelists about. And today, again, today's topic is focused on upper tract urothelial cancer, which lies halfway between bladder cancer and kidney cancer. So please ask away any questions you need to have answered by the pros. We have them here together today, which is really fun. And also, I will share some websites that we have where anyone at any time can ask us questions or get a referral or contact us, and we do monitor and read those carefully. So I'll give you those in a second. So let's just wait one more 30 seconds and then we'll get going. Okay, we'll get started here because we have a lot to cover, and it's a great fun, no slides, just conversation. So please ask away. So thank you all for joining us again. Dr. McConkey, our director of the Greenberg Bladder Cancer Institute, is giving a lecture this afternoon. So he asked me to step in, and those are big shoes to fill. Today, we're joined by Dr. Nirmish Singla and Jeannie Hoffman-Censits for a interesting and fascinating and updating conversation on what's going on in upper tract urothelial cancer, which, believe it or not, the Greenberg Bladder Cancer Institute has become somewhat, thanks to these two, expert in. It's been a fascinating and unforeseen twist of events where UTUC is a big part of the portfolio. But first of all, we're grateful that you're here and we hope you're enjoying a great spring. As you know, I'll read this. We're always expanding or trying to expand our educational offerings, including our growing collection of programming. And we're blessed to have a women's only program based out of Sibley, led by Doctors Armine Smith and our own Jeannie Hoffman-Censits. She does many, many things. And with team member Pamela Getz at Sibley, we have quarterly women's program webinars, and also a women-only support group based out of Sibley, which is Johns Hopkins, and it's for women with bladder cancer. We have two easy access ways to contact us where your questions, even a question here that we didn't get to or didn't answer properly, or if you are interested in a trial or have a question or a referral, they're pretty easy. And so the first one, reach out if it's bladder cancer related, it's bladdercancer@jhmi.edu. And for you upper tract urothelial questions, referrals, trials, anything UTUC, easier to say, the website is utuc@jhmi.edu. What does jhmi.edu stand for? I always wondered about that. It's Johns Hopkins Medical Institutions at edu. So bladder cancer at jhmi.edu or UTUC at blah, blah, blah. Okay, before we introduce today's session, we have on our website something that may be helpful because we're so spread out. There's clinics everywhere, different locations. There is a bladder cancer patient navigation page, which lists phone numbers, which lists email addresses, which lists locations and floor numbers for all the different clinics and all the different programs we have. And it's on our website, prominent, and that can help you navigate if you're coming for an appointment or want to make an appointment, the right phone number, who to call, etc. It's extensive. And so that's sort of a helpful tool for you. And that's embedded in our website, which is, if you Google the Johns Hopkins Greenberg Bladder Cancer Institute, all of this lives there. We also, I'm proud to let you know, we have a new newsletter. Here it is, just published. It's a little blurry. That is in print or is now available by email. And it highlights the research portfolios of all our investigators, including Dr. Singla and Dr. Jeannie Hoffman-Censits. And we're proud to say that, wow, there's been a lot of progress in 10 years. And this is called the research issue, and it looks at all the research going on. Very robust research programs for bladder cancer and upper tract cancers. And I hope you get a copy and read it, and you'll see what our investigators are doing. You'll also meet our young lab people who are so amazing and so interesting, postdoc fellows and PhD students, and all these brilliant young people who kind of work behind the scenes. We wanted to bring them to life for you. And let's see, next month on May 1st, we have a fantastic program before we take a teeny break for the summer with a Dr. Cynthia Boyd. She is a chief of geriatric medicine at Hopkins, but she's one of the rare, unique clinicians who sees the whole sort of spectrum of what's happening in aging for patients, no matter what they have. She sort of puts the whole picture together. She's a remarkable human, and she's also a very gifted comprehensive physician who will see, she doesn't sort of just say that, oh, you have bladder cancer and you have diabetes and you have this or that, or she sort of puts the whole picture together, and she'll talk about the aging process in cancer and what she sees, and what really some great tips on how to sort of navigate that. So Cynthia Boyd, she's remarkable, fantastic speaker, great person, May 1st. And and all of our programming can be found on our website. We are going to take a break for the summer for June, July, August, I think. And then we'll be back in September. So today, I'm pleased to introduce our expert leaders in upper tract urothelial cancer. And a special welcome to Dr. Nirmish Singla and Jeannie Hoffman-Censits. Let me tell you about them. Dr. Singla is an assistant professor of urology and oncology at the Brady Urological Institute. He serves as the director of translational research in genitourinary oncology and helps lead the multidisciplinary kidney cancer program at Hopkins. But that's not all. He leads the kidney cancer multi-D clinic with Dr. Jeannie. We're going to call her Dr. Jeannie today, the UTUC. And you just announced, Nirmish, that there's also there's kidney and testicular, and you just created a whole new bunch of multi-D clinics, which is incredible. We'll talk about that. He attended the University of Michigan Medical School. He completed his residency in urologic surgery at University of Texas Southwestern. He then completed a specialized clinical fellowship in urologic oncology at Memorial Sloan Kettering, and through the Society of Urologic Oncology, SUO, as well. That's a mouthful. Totally blessed to have you. And it's been maybe 3-4 years since you've been with us. Is that right? Something like that. Yeah. 5. Okay, we're going on 5. Dr. Jeannie Hoffman-Censits is, Dr. Jeannie, as we call her, is the associate professor of oncology, medical oncologist, and she cares for patients with urothelial cancers of the bladder and upper tract. In addition to her work in UTUC, she serves as co-leader of the Women's Bladder Cancer Program at Sibley. Dr. Hoffman-Censits received her undergraduate degree in neuroscience from Trinity College. She earned her MD from the Sidney Kimmel Medical College of Thomas Jefferson University, and she completed her residency at Thomas Jefferson University Hospital and performed a fellowship in hematology and oncology at the Temple University Medical Center. She joined our faculty in 2018. Nirmish and Jeannie, I'm going to call you by your first names. I hope that's okay. Welcome, welcome, and thank you for coming and joining us in this day. And thank you actually for being like the experts in UTUC. We were just talking about it offline, and I looked it up. UTUC seems to be fairly rare, with about maybe 7,000 published cases a year. And so I wanted to ask you both about you and then about UTUC. So Jeannie, can you share with us how you sort of became interested in UTUC, if it's such a rare cancer, or that how did you meet?
How do I meet UTUC? Can you hear me okay?
Yes. Yeah.
Yeah. So before the amazing opportunity to come to Hopkins, I spent a lot of my career in Philadelphia, and always interested in and started my career as a general medical oncologist, taking care of all urinary malignancies, so prostate cancer, kidney cancer, bladder and upper tract disease, as a part of a multidisciplinary clinic. And, different centers develop different expertise, based on the faculty and staff that they have available. So we were just sharing a little bit earlier that Dr. Singla is aware of an instrument that was named after a mentor I worked with in urology named Dr. Demetrius Bagley, who invented some of the scopes that can get all the way up into the upper tract, because that was really his area of interest. And I think more so in terms of taking care of stones, but I think as physicians, and especially urologists who work with different tools, and surgeons can use different tools for different things. Some of those scopes, Dr. Singla can tell us a little bit better, probably evolved in terms of the diagnosis and even treatment of upper tract lesions. So, walking into these multidisciplinary clinics, I just wound up seeing a lot of patients of Dr. Bagley's who were diagnosed with disease in the ureter and the renal pelvis. So a little bit just by showing up to work every day, I became super interested and fascinated, and got a wonderful education from that multidisciplinary team. And really not a lot of medical oncologists at the time, or even now, kind of, I think felt like that was an area of focus. And for me, I felt like, wow, what an unmet need, what an interesting population, what a challenging problem to have, to have a urothelial cancer that could be in a difficult location to get to, and causing things like blockage, bleeding, obstruction, some of the special problems that patients with UTUC can have. So that's a little roundabout way about how I came to see a lot of these patients and develop that expertise.
That's wonderful. And Dr. Singla, how about you? Did you have a course in UTUC in all your magnificent training, or because it's rare, I'm wondering, did it find you, or you find it, as Jeannie did?
Yeah, no, I think like you said, it's a very rare disease. Certainly not something that we typically would get didactic instruction for. For example, during medical school, it's usually not a topic that would be necessarily emphasized. For me, it also just like Jeannie had said, it sort of boils down to the people we work with and the mentors we have. And actually, I was very lucky that both in residency as well as in fellowship, some of my mentors who are now close collaborators with us on the UTUC front were very interested in these disease spaces. For example, in residency, Dr. Vitaly Margulis in particular is actually one of the urologists who worked very closely with Jeannie in one of the phase 2 neoadjuvant chemotherapy trial for UTUC. And that's actually being sort of under his wing during my training was one way that I got a lot of exposure to this area. And it's also, I think, a way to just simply get my foot in the door with a lot of the ongoing research and a lot of the questions. And it's sort of a space that, as urologists, a lot of people sort of gravitate sometimes towards operating in the retroperitoneum or the upper urinary tract, or gravitating towards sort of operating in the lower urinary tract. But this is kind of a unique space that kind of combines the two, or sort of a hybrid between the two areas, between the kidney and the bladder. And so it kind of is a way to kind of bridge both areas, I would say. And then also in fellowship, Dr. Jonathan Coleman was one of my mentors at Memorial Sloan Kettering, and he also is now one of our close collaborators. But was somebody who is very also involved with UTUC research, and also had a separate prospective clinical trial on neoadjuvant chemotherapy. And so I think that honestly, in my case, it was largely serendipitous that I happened to work with great mentors, and now have had the opportunity, of course, to work with Jeannie and the team in continuing to build interest in UTUC.
Well, thank you for, most of all, thank you for the work that you've done. And also you are also training the next generation to know more about UTUC. So that's incredibly valuable. It seems to be having a moment in that it's being talked about and recognized as its own disease. So I'm going to ask one or both of you, can you just for our audience explain that it's kind of like bladder cancer, but it's kind of not, but there's kidney cancer. Can you describe, are these similar cancers? Does one lead to the other? If you have three different things happening, you have a bladder, you have ureters, and you have a kidney. Are they related or not related or sort of related? I'm going to ask any one of you to answer that.
Jeannie has a great explanation whenever we see patients in clinic, where
Oh, great.
well, UTUC and the anatomy.
I use a lot of hand signals. I think from the 30,000-foot overview, Stephanie, the bladder is a big muscular balloon, and on the inside of that balloon is a tissue called the urothelium. And I kind of think of that almost like a saran wrap that lines the inside of the bladder. And the inside of the bladder is contiguous with this plumbing system, which then leads up, into the ureter, which is like a straw that connects the kidney to the ureter down into the bladder. The kidney is a spongy kind of machine. It filters the blood and it produces urine. That filtered urine first dumps from the spongy kidney, the organ, into the renal pelvis, which is connected into the kidney, kind of sitting within it. And so the renal pelvis, which is a reservoir, the ureter, which is a straw that dumps into the bladder, is all one contiguous system. So on the inside, if you were to drive a car, one of these ureteroscopes all the way up, the tissue would look the same, and you could get all the way up there. The spongy part of the organ, which is the kidney, is a different tissue type altogether. And in fact, I don't even see tumors of the kidney anymore, because the etiology, how they develop, what they look like under the microscope, how they're treated, how they behave, is just completely different than how tumors within that collecting or that plumbing system behave.
Oh, that's really interesting.
How'd I do, Nirmish? Okay.
That's fantastic. Better than I would have been able to explain.
So back to the bladder and the ureters, are they treated differently? Different drugs, or they're similar but not the same?
I think it's a yes and a no, kind of depending. So if someone has a tumor that started in the ureter that has moved or metastasized into the lung, that initial treatment might not be different.
Oh.
If somebody has a low-grade tumor of the ureter and they have one ureter, that tumor may be treated differently than a low-grade tumor of the bladder. So some of it is really depending on location, grade, what else you kind of have, and maybe that's a better question for Dr. Singla to kind of answer, because of some of the kind of physical limitations, within this plumbing system.
Yeah, so to your question of like bladder cancer versus upper tract urothelial cancers, for a long time, I think that they were often sort of treated as being more or less the same entity. And in many ways, I think people may consider them to almost be like disparate twins in some regards, just because it is arising from the same lining, if you will, the urothelium that Jeannie was talking about, that coats the inner lining from the kidney through the ureters down the bladder and out the urethra. But there are, more and more. So there's evidence that has been emerging that has demonstrated that they aren't necessarily the same disease, and they do, UTUC does warrant its own separate space, and this includes both on a biological or molecular level, where there are maybe similar mutations, for example, that can be seen between bladder cancer and UTUC, but perhaps at differing frequencies. Even risk factors can differ for who forms UTUC, separate from who forms, for example, bladder cancer. And then also the approaches to treatment. They are now, I think, we're learning that there may be better ways of personalizing treatment for patients with UTUC, rather than just taking an empiric approach of extrapolating data that we have from bladder cancer patients to UTUC. And so while there is certainly a relationship between the two, and I think one of the questions from the audience was pertaining to how often is it a diagnosis in isolation versus a diagnosis as a result of having had a history of bladder cancer. There is some interrelationship there. I think that patients who have had a history of bladder cancer have a slightly increased risk of having recurrence in the upper tract. It's just about shy of 5% or so risk of recurrence. The rate is a little bit higher for patients who have a history of UTUC for developing a subsequent bladder cancer. So the opposite is actually on the scale, depending on which study you look at, anywhere from about 25 to 50% of patients with UTUC might develop bladder cancer. Some of that's mechanical because urine flows from the kidneys down to the bladder. And so, whether it's simply just that the tumor is now seeding into the bladder as the urine makes its way out, or whether it's because of inherent risk factors and just that the lining of the tract is predisposed to forming these tumors, I think is maybe a subject for debate. But there is some relationship, but there are also some differences. That's sort of what I would say is kind of the bottom line.
How does one know that how is one diagnosed with upper tract? Do they show hematuria and blood in the urine, and they come to you and say, what's going on? And is that how you diagnose it? And also, are there any diagnostic tests to show for upper tract?
Yeah, it's a good question. I think diagnosis of UTUC is often one that's not as straightforward, and I think compared to bladder cancer, where I think it's much more frequently encountered in the setting of hematuria or blood in the urine. It can be a little bit more elusive for UTUC, simply because it may just be microscopic blood in the urine that's not always as apparent. Sometimes patients may have flank pain or discomfort if a tumor is causing obstruction. But a lot of times these can be indolent findings, and certainly having sort of a low threshold for suspicion, or a high degree of suspicion would be necessary. Typically, the classic workup for someone who does have blood in the urine is to do a cystoscopy of looking in the lower urinary tract to look for bladder tumors. But then the other half of that is to also get imaging of the upper urinary tract, usually a CT scan called a CT urogram. And it's the CT scan that would be able to diagnose tumors in the upper urinary tract. And we are certainly in need of better imaging to better detect, especially smaller tumors. So there are limitations to that, not to mention limitations of who can actually get a CT scan with contrast because of kidney function or other reasons. And so there are certainly a lot of needs in terms of diagnosis. A lot of patients are diagnosed with some degree of delay from either their presenting symptoms or from even an initial consultation with a provider. Sometimes actually catching these tumors can be rather difficult to do. And so I think these are really the challenges we face as clinicians.
So when you have a scope and you're looking at the bladder, is it common practice that you would also look at the ureters, or maybe not?
So usually with office cystoscopy, so most of the time when we're doing these diagnostic cystoscopies, they're done in an office setting, typically with a flexible scope. We generally don't go up the ureters without anesthesia most of the time. And so because it is in general such a low frequency that we would find these tumors, it's not part of routine screening to do ureteroscopy. But typically if a cystoscopy, for example, if one were to find a positive cytology in the urine, but nothing visibly apparent on a cystoscopy, or if there is some finding on a CT scan in the upper urinary tract suggestive of UTUC, these would be situations in which it would be appropriate to then evaluate those findings further under anesthesia with a ureteroscope. But generally, it's not part of sort of the routine screening tests, let's say, for or evaluation that you would do for someone who is found to have blood in the urine.
Wow, that's so helpful to picture what it's sort of how it presents and the mysteries of it, or the, it's hiding in plain sight, I suppose. But you did mention something that sort of breaks my heart, that oftentimes it's advanced by the time it comes to you. And does that mean it presents as, if you can get a sample because it's teeny weeny, right? Is it a high grade? It typically presents as higher grade than you would like it to be when someone comes in for the first time because they haven't been scoped, or they have no idea what that is, UTUC. I'm sure it's the first time people have even heard of it. Do patients present with more sort of serious high grade disease when they come to you in general?
I would say it's a bit of a spectrum. I think there are certainly a number of low-grade cases that we also encounter in the office. I think I probably see, I think if you ask Jeannie and if you ask me, I think our practices are slightly biased in different directions, and then we sort of collide in the MDC setting. So I do tend to see a little bit more of the localized and perhaps low-grade patients. Maybe Jeannie can comment a bit on what she sees in terms of volume of more advanced disease.
Which leads me to ask you about the multi-D clinic. Please explain it, how it works, and what would a patient be expecting if they came to you for UTUC? So is it day of the
Yeah,
week?
I'll take a stab at this, Stephanie. So
You're in the same place at the same time, which in medicine is a really big deal, right? You're in the same location and you could see two at the same time rather than make separate appointments at separate times and wait torturously in between. So this is a real asset to humanity.
Exactly. So the concept of multidisciplinary clinics and multidisciplinary care is not at all new. I think especially in urologic oncology, which we practice with, in urothelial cancer of the bladder, if somebody has an isolated, tumor, a medical oncologist, a radiation oncologist, a radiologist, pathologist, multiple people kind of come together to make treatment decisions. And we do this all the time in a multidisciplinary setting, whether or not it's a conversation on the phone or an email chat or a tumor board. There's very few patients I ever take care of, even in the advanced setting, in isolation. So there's always input, from the surgical team and from others in terms of kind of moving forward with care. But when someone's going to lose an organ, and when there's, different ways of approaching a complicated problem, to be able to get to know that patient together, either for the first time or for one of us to see the patient and follow up, and the other one for us to introduce the patient, to the surgeon and to radiology, I think is really important. And to do that with the expertise of our team that really sees a high volume of patients with these complicated problems and understands some of the special challenges that come with losing part of the ureter, or losing the entire renal unit, which is the kidney, the ureter, lymph nodes coming out, deciding if someone is a good candidate well enough to get chemotherapy maybe before surgery, or is this someone we should wait until after? These can be complicated discussions, and to present that together to the patient, for us each to come from our own perspective, from a chemo perspective, from a surgical perspective, and to have the expert radiologist that's now been joining us, and
Wow.
a nephrologist, a kidney specialist that's engaged with our team, we feel like we can deliver just the best possible care, you know, in that setting for in real time together, as we get to know the patient and the family and the support people that they bring with them, so we can talk about this all in the same space.
Wow, that's really wonderful. So on a certain day, you're together with the team, and then a patient and their families and are evaluated, and then there's this sort of a care plan that's brought about, that's suggested based on what you know, both of you, two heads or three heads or four heads are much better than one. Oh, tell me about the role of radiology in upper tract. I wasn't really aware of that.
I'll let Dr. Singla kind of
I mean, radiation, right?
Radiology, not as much
Radiology,
radiation
yeah.
oncology, every
Oh.
once in a while, but radiology.
Oh, okay. So not so much radiation itself, but go ahead, answer.
Yeah, so you know, I think we're very lucky that it's you know, when it comes to different areas of interest and expertise and niches, I think at Johns Hopkins we're very lucky that there you can find someone who's sort of interested in the same thing you're interested in, even in other departments. And so outside of urology and medical oncology, between myself and Jeannie. We do also have a partner on the diagnostic radiology side, because imaging plays a big role in understanding, you know, is there a lesion in the urinary tract? Is there a site of metastasis? Are there enlarged lymph nodes? Sometimes these findings can be equivocal, and we need an expert to weigh in. And Dr. Farzad Sedegat is actually our sort of partner on the radiology side. And it's not only just simply sending him an email to look at an image, but he actually does, you know, come to our clinics and meets with patients together with us. And patients definitely appreciate that. And oftentimes, you know, patients may have questions related to their scans that they just got done, or, you know, want to know more about their likelihood that something is concerning, and having, you know, someone who's a specialist in looking at these scans can be very helpful to have. And he's you know, he's someone that's very engaged and interested in this disease space, and so that really is an added plus. And like Jeannie said, you know, even beyond that, having Dr. Derek Fine, who's a nephrologist at Johns Hopkins, also with an interest in onconephrology, or basically kind of the nephrology in patients with cancer. That's another area that we've been able to engage for a disease where especially kidney function is something that's paramount, when thinking about, you know, therapies that patients are eligible for, or toxicities from therapies, and then also, you know, issues related to kidney function after a definitive surgery that a kidney would potentially remove a kidney. So that's where this sort of team based approach comes into play, and I think patients really appreciate having, especially those who come from out of state, or even potentially from out of country. You know, it's sometimes infeasible for them to have to make multiple trips to see different providers. And so having it all kind of bundled in one, if you will, one sort of encounter, is kind of I think a way that a lot of patients appreciate this sort of MDC type setting.
Right. Well, thank you for doing it. And for someone who wants to maybe consider coming to your MDC, do they just email or the UTUC, or reach out to you? Is that how a patient gets connected? Is that how that works? Or maybe you already have them as patients, or I'm under the impression that people are flocking to your clinics because you are becoming, and you should be proud, more, you know, really expert in this, and it's one of the few MDCs probably in the country, as I understand it. Not because, yes, because you're fabulous, but also you're really sort of understanding this subset of urothelial cancer that clearly is sort of a new thing to look at. Question about treatments for lower grade disease, however you define that, and for more advanced disease, even metastatic, where this is where you both come in. Dr. Singla, you're a surgeon. Jeannie, you're an oncologist. What are some of the treatments, and are there any new treatments that are coming down the road? And then that will lead me into a question about your research and some clinical trials going on.
I'm happy to start and give an overview if you'd like, Jeannie, or however you
It's almost like
prefer.
you're
Yeah,
a team.
no, it sounded like Stephanie was asking about low-grade disease, so I was gonna
Start with low grade and
ask
then
that question
Sure,
to
sure.
we don't want it to get any more, but it,
you.
Yeah. Well, I think just sort of piggybacking on your, I think you had a question in the last sort of discussion regarding the MDC. So as far as kind of referrals and patients coming to our clinics, there are a number of ways. So occasionally patients may come to my clinic or come to Jeannie's clinic, or simply be referred from another provider. Sometimes Jeannie or I may make a call that basically like, hey, this is a patient that would benefit from having a discussion with both of us, or really require this multimodal approach. Sometimes we do get external referrals. I think that email address you mentioned at the beginning, utuc@jhmi.edu, is a way that we do receive a number of referrals as well, sometimes directly from patients, sometimes from external providers. Um, Occasionally, either Jeannie or I might get direct emails as well. But I think we, at sort of the end of the day, as far as determining who would be the best candidate for the MDC. Each individual case is typically vetted by Jeannie or myself or both of us. And then we sort of determine, this would be a patient who would actually need to meet with both of us. But then sometimes there may be situations where a patient may only need a urologist or may only need a medical oncologist as far as driving the primary management. And so we kind of try to make that individualized assessment. And so that maybe leads into the segues nicely into kind of the treatment discussion based on aggressiveness. So the way that we sort of maybe kind of like a 1,000-point view, I suppose, the way that we sort of kind of view UTUC treatment is kind of based on a couple of things. One is sort of just the global picture, the stage of a patient. So does it look like this is a tumor that that is predominantly localized? It's just within the urinary tract. It's not extending to it's not clearly involving any other organs or lymph nodes or other sites. And so that's, I think, step one, because oftentimes the approach, generally speaking, for patients who have more widespread involvement is typically something that would fall under Dr. Hoffman-Censits expertise with systemic therapies. If they're just confined to the kidney or urinary tract, that's where we sometimes do a little bit more digging about their grade, because grade is often what can help influence whether we can manage tumors without having to do anything radical. So, for example, in the setting of low-grade disease, we try our best. It's sort of a balance between kind of maintaining control from a cancer perspective, but then also trying to preserve kidney function. And so, fortunately, these tumors are the type that don't often tend to invade or spread when they're lower grade. And so these are the types of tumors that we try as well as we can to manage, usually using your ureteroscope or using topical techniques that I can certainly talk about here momentarily. But in general, we try not to subject patients with low-grade disease to undergoing a radical surgery where you're removing a kidney and the whole ureter, with the exception of cases that are maybe harder to treat endoscopically. Classically, our approaches for low-grade disease are usually either using a laser fiber to ablate these tumors. And we actually have a new trial, a recent trial that we have become a part of. It's a global trial called Enlighted, which uses a sort of a novel type of laser that is directed towards basically it's something called photodynamic therapy. So patients are administered an agent that localizes to vasculature, and then using a specific wavelength. The idea is that you'd be able to just target tumors where this agent is taken up. So that's also kind of under this category of lasers. And then we also, actually, Johns Hopkins was part of a clinical trial a few years ago that led to the FDA approval, the first FDA approval for or the only FDA approval actually for a treatment option for low-grade disease, which is something called Jelmyto, which is a topical form of chemotherapy that's suspended in this hydrogel that liquefies at body temperature, but is is actually, sorry, that solidifies at body temperature, but is liquid at colder temperatures. And so it has a better contact time with the inner lining of the urinary tract. And that helps for the upper tract in particular. When we start getting into high-grade disease, it's a little bit more nuanced. That's from a surgical perspective, these are usually the tumors that we are often more tend to be more aggressive with, and so the gold standard approach is usually to do a more radical surgery. Sometimes you can get away with just removing like a little portion of ureter and save the kidney, but most of the time, if it's more extensive involvement or if it's too high up and it's going to be challenging to reconnect the plumbing to reconstruct the urinary tract. The general principle would be to remove the kidney and the ureter. But the nuance that comes into play here is maybe something Jeannie can talk a little bit more about, is that we're now having more and more evidence that's mounting that's essentially supporting the use of therapy in addition to surgery for patients with high-grade, even non-metastatic disease. And that's where having this multimodal approach can be beneficial, potentially beneficial for a number of patients.
Wow. I'm going to stop you right there. We may have asked this before in other webinars, but we all have two kidneys, or should, and if the UTC is presenting in one ureter and you have to remove that kidney and that ureter, but the other one is fine, there's no evidence of cancer or disease, and it's functioning fine. It's true that people live very happy, robust lives with one kidney. Is that kind of the idea that you have two? They're never redundant, but you can survive very well on one. Is that kind of how that works?
Absolutely, yeah. I mean, I think there are risk factors for chronic kidney disease. What I would say is that certainly the ability, so with one kidney, I think many patients live with one kidney and are far from dialysis. The overall kidney function may be compromised to some degree, but the important aspect is to maintain stability of the kidney function long term, rather than see a progressive decline in the kidney function. And that's where partnering with nephrologists like Dr. Fine can come in handy to help reduce that potential risk. But a number of patients do live happy, normal lives without having to make any substantial lifestyle changes in terms of diet or exercise, even maintaining adequate hydration, maintaining good blood pressure, blood glucose control, avoiding bad habits like smoking. These are some of the aspects, and then also kind of reviewing some of the medications that patients might be taking that could be cleared by the kidneys. These are, again, just broadly, I think a nephrologist could talk about this much better than I could, but these are broadly some principles that may help with kidney health in the long term, and help preserve, even with one kidney, the ability to maintain your overall kidney function.
Wow. So Jeannie, what about the treatments that you would maybe suggest? And this is a broad question depending on the case and what the severity is or not severity. What are some things in your tools in your toolbox?
Sure. One of the main discussions that Nirmish and I may have in a multidisciplinary clinic is if somebody has a high-grade tumor in the ureter, the renal pelvis, and the plan ultimately is, for surgery, one question is, should that patient get chemotherapy? And when we talk about chemotherapy and around the time of surgery, we're really talking about a drug called cisplatin. And prior to surgery, it's really the only drug that we have probably the most data on that would kind of, with the best evidence that we have, lead a surgeon to kind of hold off on doing a surgery with the intent to cure that patient of their cancer so they can get preoperative, what we call neoadjuvant chemo. So for years, we've been doing this in bladder cancer. And the reason that we do it is because we know that giving that chemotherapy prior to a big surgery where someone would remove the bladder because they have a tumor in their bladder, that it improves overall survival. Cisplatin chemotherapy is a rough drug though. And so, not all of our patients with urothelial cancer, who, as you know, tend to be older and can have impaired kidney function, trouble with their hearing, cardiac difficulty. problems with their functional status, your ability to kind of get up and go and tolerate toxic therapy. But even kind of more, kind of special and concerning with the population of patients in upper tract, because the drug is both metabolized or broken down and cleared by the urinary system, by your kidneys, then also potentially toxic at the same time. So with a balance, giving chemotherapy that we would hope would help the patient potentially live longer and do better by treating the cancer up front, but then also weighing that with the risk of potentially causing harm and impacting their kidney function. We don't ultimately ever want to get to a point where someone would not be a good candidate for surgery because we've impacted their kidney function. Why would we even think about doing that chemotherapy before taking out someone's kidney? We do that for a couple different reasons. So one is, if you have two kidneys, it's more likely than not always, that your kidney function is going to be better before surgery. So you can use that diseased kidney to actually metabolize the treatment. And the second is if you give treatment with a tumor in place, then you get to see whether or not that treatment affected the tumor. So if you resect a tumor, someone recovers from surgery and give chemotherapy, 2 or 3 months later, you're kind of doing that blind. It's, there may or may not be an opportunity to get a sense of whether or not that person in particular for that cancer is getting a benefit from that therapy. But, whether or not it's in the urothelial cancer setting or in the breast cancer setting or lung cancer setting, the concept of doing chemotherapy upfront ahead of surgery is one that we do kind of across oncology, which is in part helps us to get a biological assessment as to whether or not that chemotherapy helped. So we make that decision, yes or no, does this tumor kind of necessitate the use of chemotherapy? And does this patient who has the tumor, are they a good candidate? Do we think that we're going to do more good than harm by kind of exposing them to the treatment and delaying their surgery? And we do that because, again, extrapolating a little bit from bladder cancer, but then also, Dr. Singla alluded to one of the clinical trials that was run by our team, within something called a cooperative group, and giving bladder cancer chemotherapy to patients with upper tract disease and getting a sense that this was safe and relatively tolerable, and that we were seeing rates of what's called tumor downstaging, tumors going from being invasive to completely responding to chemotherapy or going away, somewhere between like 14 and 19%. And that's been reproduced by another group at Sloan Kettering. So we're starting to get some additional data and have an ongoing clinical trial to kind of keep testing this concept, and now kind of with the addition of other therapies. If someone goes through chemotherapy and they have their surgery, and 10 to 14 days after surgery, we see a pathology report that we say, okay, this is favorable. Cancer was eliminated, it's gone. We don't see any traces of it. That's great news, and we feel confident that no other therapy is probably at that point needed, and so that patient would move on to just get their follow-up imaging every few months, as well as the cystoscopy, or look inside the bladder to be sure that there's no new cancer kind of growing up. But if on the other hand, a tumor lives through chemotherapy and the patient, put up with the toxicity, the hair loss, nausea, blood count issues, then that cancer is telling us something. It's aggressive, and it could withstand that treatment, which means no more of that same treatment makes sense. And so we would then discuss, should we do something after surgery? And that's called the adjuvant setting. And now there have been a few studies that indicate that may be a good idea for selected patients, again, based on what their cancer stage is, sometimes depending on the biology. So lots of kind of points of making treatment decisions kind of based on the tumor, the location, the size, the grade, as well as the person, that has that cancer, their comorbidities, or what medical, issues they have and what they bring, and their willingness to go through all this. Everyone has to really understand what's going on with their body, you know, why we would even talk about doing something like this, why some people we would recommend chemo and others not, and then the expectations of, you know, patients and families of how much time is needed to take off work. You know, we live 2 hours from the cancer center. Is this something specialized here? Can it be done closer to home? Or we flew to see you? Do we have to you know, there's a lot that comes with these discussions, not just a yes or no about treatment, but, you know, what does this mean to me and my family, and what impact is going to have in the short term is a big deal.
Thank you for that beautiful explanation. Tell us about immunotherapy and some of these new drugs that have been FDA approved. Among them, as I understand it, EV and Pembro. And can you explain what those are? And they seem to are being used in UTUC treatments.
Yeah. So when we talk about like modern immunotherapy, you know, as you mentioned, pembrolizumab, or called Pembro. There's TV commercials about it. Keytruda. This is what President Carter got for his melanoma. These immunotherapy drugs that are intravenous are approved for a multitude of different cancers, including lymphomas. So across the board, we are now seeing not just treatments that are for breast cancer or colon cancer, but what's called tumor agnostic, which means it doesn't matter what kind of cancer you have, the treatment kind of works across the board. Not for every single kind of cancer, but for urothelial cancer, really important, you know, toolkit. And so there's several different drugs that have been FDA approved in different spaces. So what that means is, based on how they've been tested, and for what kind of disease state, we can use different drugs. So pembrolizumab or Keytruda is the one that's been tested probably the most in terms of how many different places within someone's cancer history we can give it, including non-muscle invasive bladder cancer. But you know, some of this idea stems from more what we call topical immunotherapy, or treatment that goes inside the bladder and sometimes gets dripped into the urinary system from above, and that's BCG, which, you know, a lot of people on the call may have seen before, may have had before. Dr. Singla has certainly, you know, given a lot of it before, but that's a very different kind of immunotherapy. So I think, you know, if you're talking to a general audience of patients that have cancer, they may not know anything about BCG, but, you know, for those with a urothelial cancer history, we have a sophisticated audience, you know, and so they may have seen this before, have heard of this before, but they really are kind of two disparate animals. So again, kind of more from the 30,000-foot view of like what immunotherapy does. You know, our immune system was born the same day that we were. You know, it's a system. It's like our central nervous system, or like our cardiac system. Instead of there, it functions. You don't even think about it until it maybe works or doesn't work so well. And it gets educated, and it gets educated in different ways. So, you know, in childhood, both from vaccinations and from infections, it learns, you know, what are foreign things that should be attacked, like viruses and bacteria. These things attack our own cells, and the immune system is supposed to recognize like what's self, and kind of what's foreign. And I think for a long time, the notion of like what the immune system did was more basic, you know, in terms of that. Like, it's supposed to fight off foreign things that come from the outside. But there's also this understanding that for some patients, there's a dysfunction of the immune system, where the immune system has a hard time recognizing what is self. And that's where autoimmune disease can come, lupus and rheumatoid arthritis, and those kinds of diseases that can really be, you know, quite devastating. So we know, you know, fight external things or things that shouldn't be in our bodies. Don't attack yourself. And so with those rules in place, there's this other special thing that the immune system is supposed to do, which is survey and recognize when normal cells turn into abnormal cells for different reasons. And one of those reasons is because cancers can develop in our bodies, and they're probably developing all the time. And, you know, over time, they're going to start to look different than normal cells. But the problem is they look normal enough that a normal immune system thinks, you don't look quite right, but you look normal enough that my rule is I'm not supposed to attack you. And really kind of playing on that concept is where these drugs essentially were born in different ways. And so what they allow the immune system to do, that if someone's immune system has recognized that there's a cancer cell in the body, and we can see this sometimes microscopically looking at what we call hot tumors, or tumors that are immune infiltrated, you can see that there's a lot of cells around the cancer, but the cancer is not being killed off by the immune system because the immune system feels somewhat paralyzed to do anything. These drugs like Keytruda and atezolizumab and nivolumab will break the agreement the immune system essentially has and kind of release the brake. And so those cells that are kind of poised to kill can just go ahead and start killing the cancer. So it's not the drug per se that's actually doing something like we have with chemotherapy, where it's like a direct hit, but it's really just an allowance of, letting the immune system do what it's kind of poised to do. The issue is that when you change the rules of how the immune system has been behaving your whole life, that system can not only kill the cancer, but can start causing other problems. And that's where some of the side effects can come, be it a skin rash, colitis, pneumonitis, myocarditis, any organ in your body can be affected at any time. And it doesn't have to be, it doesn't have to go along with kind of when the drug has been administered. So it's really it's a very, very powerful tool. And these immunotherapy drugs are unlike anything that we've seen before. And they've really, they've been just transformative, and both for urothelial cancer and a lot of other cancers.
You are prescribing them for certain patients for UTUC.
Yeah. So in clinical trials, we've been using these drugs since the early, like mid 2000s, and approved since 2016, with multiple different drugs approved in sequence and now in different settings.
So you can, with those who have been approved by the FDA, you can prescribe them. And then for newer cocktails, would a patient be referred to a trial? Is that how that works?
It depends. So one of the newer cocktails that is now FDA approved, we have two combinations in advanced urothelial cancer that are FDA approved. So one of them is for a more traditional backbone of chemotherapy, cisplatin and gemcitabine, that we've been using for literally decades, Stephanie. There was a clinical trial done and presented last year and published, where combining cisplatin, gemcitabine, standard backbone with one of the immunotherapy drugs called nivolumab, that improved overall survival compared to cisplatin and gemcitabine alone. So we've been using that combination, that cocktail. And then also now you've alluded to enfortumab vedotin. So that plus pembrolizumab is another new standard of care that we've been using in different settings for a little over a year, but now that is also FDA approved. So enfortumab vedotin is a newer class of chemotherapy drugs. It's I call it like a smart bomb of chemotherapy, because it's designed with the same concept of more traditional chemotherapy like cisplatin, but the delivery system is quite different. So older kind of chemotherapy like cisplatin, it's given in a certain amount, and it's a powdered drug that gets mixed in a solution and then hung in an IV bag, and that drug just circulates through your entire body with the hope that it gets to cancer cells, but not so many normal cells that it causes so much toxicity. But kind of capitalizing on the fact that cancer cells are sensitive to chemotherapy, what enfortumab is and what sacituzumab is and other drugs that are FDA approved for other kinds of cancers, is taking that chemotherapy, instead of letting it run free, encapsulating it, and then attaching it to an antibody. So it circulates in the system, theoretically, with the hope that it can find the cancer cell and then direct that chemotherapy to the cancer cell. So you can get a higher rate of cancer killing, of anti-cancer therapy, with less delivery of those drugs, to normal tissues. So really a very cool concept. And with the hope that you can, kill cancer cells with the enfortumab and then stimulate the immune system so that and kind of change the rules at the same time with the pembrolizumab so that you get this enhanced effect. And the results are really have been quite remarkable. Yeah.
Thank you for that. Amazing. So we're almost at the hour, but I have one sort of final question, and there's no final question because I could talk to you for 3 hours. And thank you both for doing this. Is it a golden age for you upper tract cancers, understanding it, diagnosing it better therapeutics? It seems that this didn't exist even 2 or 3 years ago. What you're, our pioneers here. Moving forward, do you see better treatments, more therapeutics, better understanding of specifically upper tract as we move along here?
I mean, I would say absolutely yes. And for a couple different reasons. So, Stephanie, for decades, so before 2016, there was no new drugs FDA approved for urothelial cancer, whether or not it's bladder cancer or upper tract disease. And so when new agents come along, and for some patients, those agents work great, for some patients, they don't, we're curious, beasts by nature. We want to understand why and like which tumors and who can we select for certain therapies? Why does it work for Sally, but not Bob? And like, what is different about either the patient or the cancer? And so as we have these new treatments and new options that we can think about, I think those differences in the biology between upper tract and lower tract or bladder cancer become, much more interesting because you actually have drugs that we can use. One of the other things that's happened in the last couple of years is, as Dr. Singla also said, when it comes to clinical trials and testing new drugs, we don't necessarily, especially in the late line setting or someone with metastatic disease, we don't necessarily say, well, we want, half bladder cancer patients, half upper tract patients. We just let everybody in, with urothelial cancer. And oftentimes, because urothelial cancer is less common, you're just seeing less of those patients. But I think now people are intentionally doing clinical trials for patients that have upper tract disease and saying we actually need to put in guidelines about how you're supposed to diagnose this, when you're supposed to scope, what you're supposed to scope, how you're supposed to think about these patients. And so a new guideline has actually been put into place, which is I think really exciting, so that urologists like across the world have something to refer to when they're thinking about what to do in the clinic, which is really important.
Wow, so amazing. Dr. Singla, and what's some parting words from you for us?
Yeah, no, I mean, I think Dr. Hoffman-Censits said it best, but I fully would agree that we're in a golden era when it comes to UTUC. There's a lot more awareness, a lot more interest, studying things ranging from the biology and fundamental of the disease aspects of the disease to, thinking about ways we can better diagnose UTUC and ways that we can personalize therapies for patients. So across the spectrum, I think, especially now we have guidelines, national guidelines for the first time that were released last year, and Dr. Hoffman-Censits was part of that panel.
Yeah.
And so I think that these are all important milestones for UTUC, and it can only go, we can only get better from here. So I think what I would say is that we're on the right track now for UTUC.
Well, thank you for caring about UTUC and for all the patients that you serve, who they have a medical home with you too, and great discoveries behind it. So thank you so much, both of you, for your time. And thanks to everyone for joining us today. Two dates. May 1st is another presentation with Dr. Cynthia Boyd, who is a geriatrician who sort of looks at aging and the whole process, including cancer. She's a fascinating person, and we can learn a lot from her. And also for our women's bladder program on, it will be here quickly on June 18th. We have another important program for women only about titled What You Need to Know and to Manage and Cope, because cancer is hard, for any kind is hard. And there are resources and also experts who help sort of guide patients, especially in this particular urological space, to learn coping mechanisms and skills, and they have some great experts to help us along. So that one is on June 18th. Please send us your questions. Thank you both for being you and for the work you do combined, your teams, and also just the attention that you give to UC every day. And I know it's greatly appreciated. So thank you all very, very much for joining us, and we'll see you at the next one. Thanks.
Thank you.
Thanks, Stephanie. Appreciate the invitation.